Hello, my name is Ravi Vij. I'm from My Cancer Haven. And today I have with me Dr. Ken Shain, who is co-director of the Pentecost Family Myeloma Research Center at one of the larger facilities focused on myeloma in the United States at Moffitt Cancer Center. He brings a very diverse perspective because not only is he a physician, he's also a researcher, and we will talk about some of the research that he's been doing in this area. And so today we're talking really about uh, personalized therapy in multiple myeloma. Where are we? And so welcome, Ken.
Well, thank you very much for the invitation, and thank you very much for letting me participate.
So, Ken, can you give us a little historical perspective on? We've made great progress in myeloma, and we are somewhat the envy of a lot of our colleagues in other disease states that we have over the last 20 plus years, maybe 25 now, got so many drugs. How did these come to be, and how are things maybe going to change in the future?
Yeah, Ravi, great question. I think one, I'll echo what you just said, is that I always tell my patients, no one wants myeloma, but today is the best time in the history of time to have myeloma because of all the options that we do have and the success we've had over the last decade, 2 decades, 3 decades. But when you think about what we've done is we've really come to a scenario where our therapies, we finally learned we need to use therapies that are based on targeting the disease, the plasma cell, the actual site and the source of the disease. Okay. And all of our drugs are used that way. So we've defined in drugs that work and kill plasma cell biology, but they still kind of are targeting everybody. They're not unique. They're not one patient, one drug. They're not personalized in that setting, but they've been incredibly successful over time. So we know that we have things that are called proteasome inhibitors, right? They target very specific activities that are highly active in these cancer cells, these myeloma cells. Immunomodulatory drugs are now called cell mods, where they're again targeting very specific plasma cell biology. And I think the next kind of big jump was looking at monoclonal antibodies to CD38, where again, targeting something on the surface of myeloma cells. These are all things that have been incredibly successful and helped our patients do a lot better, and thankfully have been very well tolerated for the vast majority of patients. But I think we're at that point where maybe we could really take all that information and try to better personalize